the dais. TNOA President, Professor Dean Mohammed Ismail, sir. MOS President, Professor Amarnath, sir. Amarnath Sauli, sir. Professor V. Singarodivolu, sir, Director, Institute of Orthopedics and Traumatology. Professor Thirunarayanan, sir, Secretary, TNOA. Professor Pasupati, sir, our President, to be taking over as MOS. So with this, thank you, sir. We'll start the. I request everybody to kindly stand up for Nash Tamil Thai Valthu. Thank you, everyone. We'll be playing the TNOA anthem. Please continue standing.
Might be made easier, and this we are trying to make it every month, second Saturday, and we are going to give you the QR code and the link for giving your feedback. What is the right time to do it? How long you want it? What are the cases you would like to see? What clinical examination or the signs which you are not very confident of, which we can always have a feedback, and then we'll be able to show all those things. If you want any topics or anything, so that we'll be showing. So with that in mind, without wasting much time, I take another, again, I welcome you all for this program, and your participation is going to make the success. So last but not the least, the technical partner, the Corona Remedies, who are giving us the support in this, establishing this and taking this throughout the country. Previously, we were trying to concentrate on our state, and they want to take it to a bigger level. So Vasu, who has joined online, and Ramesh, who is here, and all these colleagues, I wish to express my thanks. Welcome you all again. Thank you.
Thank you, sir. As a token of our thanks, I would like to request Professor V. Singaravadivalu, sir, to honor the TNA President, Professor D. Muhammad Ismail, sir, with a shawl. Thank you, sir. I would like to request Professor Pasupati, sir, to felicitate Professor Amarnath Sauli, sir, President MOS. Thank you, sir. I request Professor Tolkapian, sir, to felicitate Professor Thirinarayanan, sir, TNOA Secretary. Thank you, sir. I would also like to thank Professor Suresh Kumar, sir, from Tirunelveli. Hope we are able to. Sir, Sir, Professor Dinesh, sir, Tirunelveli, are able to see us, sir? Can you please unmute and talk, sir? Sir, we'll go ahead, sir. Sir, thank you. Now, I'd like to request. Sir, Dinesh, sir, are you able to hear us?
Are you able to hear me?
Sherladan?
Feel honored and Irika.
Sherladan?
We are able to hear you, sir.
Okay. Thank you. Thank you. Good morning, all of you.
Yeah, thank you, sir. Thank Professor Suresh Kumar, sir. He has joined us online. We are right now in the inauguration of the MMC ROCC program, sir. Hope you're able to see us. Yeah, we'll continue
We are able
the
to see you.
inauguration.
Are you seeing us?
Yeah, we are able to see you.
Thank
I
you.
would like
Thank you.
to
Thank you.
request
Thank you,
Professor
Chairladan.
Dean Mohammed Ismail, sir, to kindly deliver the TNOA presidential address.
Respected Director, Institute of Orthopedics and Traumatology, and the immediate past president of Tamil Nadu Orthopedic Association, Professor Singar Vedivellu, respected president of Madras Orthopedic Society, Professor Amarnath Savli, secretary of Tamil Nadu Orthopedic Association, the dynamic Dr. Professor Thirudarayanan, and the president-elect of Madras Orthopedic Society, Professor Pasupati, Professors Tolgapian, Professor Antony Malraj, Professor Padani, and assistant professors of Institute of Orthopedics and Traumatology, and the dear students for whom this program is organized. I can see Mr. Narayanan, our past social worker. It's nice to be back here in the home ground. No? Nice to be surrounded by friends. And when I was very strict with the postgraduates, I had to be at that time. Those postgraduates are left. So all the youngsters here, they look very friendly and very happy to be here. And these ROCC as well as other programs, it's all started with it's the brainchild of Professor Singar Vedivellu. He definitely deserves applause. And we are very happy to continue this. I think it will go on forever. As long as CTNO is there, I think this can go on because this is going to help all the postgraduates and youngsters. I mean, young orthopedic surgeons, it is going to help. And very happy to know it's reached all the parts of Tamil Nadu, all the nooks and corners. And we have many orthopedic clubs throughout Tamil Nadu. And being a member of Tamil Nadu Orthopedic Association is very important for our profession, for our knowledge, and for the friendship. It's very important. I'm sure that all of you are already members of TNOA, associate members. And in case you have not become a member, please do join because that is the platform through which we can really come up. And all of us are here at this position because of TNOA. So I want all of you to become members if you have not become member and actively participate, actively take part in the TNOA programs. And I know that we have to start it at 12 o'clock with these short words. I'm very happy to inaugurate this ROCC, MMC ROCC. I'm sure this will continue and postgraduates can definitely clear their doubts throughout the year, not just this one occasion, throughout the year. Thank you very much.
Thank you, sir. I request Professor Amarnath Savli, sir, President MOS, to say a few words.
All dignitaries on the dais and my postgraduates here. So I can't be naming as I'm running short. Singar will sit to talk just in 2 minutes time. So I take this opportunity to congratulate my student right from D Ortho, MS Ortho, my colleague, and then my as assistant professor in the skill pop, and then as well as my colleague in Vellore Medical College for having done this dynamic work. It is really good to see him still actively continuing it. And it's a good thing for the postgraduates to update themselves. This program of Zoom meeting is a very good, and we have to keep ourselves updated with the scientific knowledge. As science grows, the orthopedic grows, everything grows. So someone should be doing academic works. That I really appreciate. The credit goes to Singar Vedivellu. So this should be appreciated each and every one. And I'm really proud of him who continues to do this teaching work and so many cadaveric last, I think so, some few months back, he did on cadaveric work in the anatomy department and so many conference meetings and things. And I really thank also our my colleague Dean Muhammad Ismail, we both got selected. And when I went to Velur and he went to Coimbatore, and then he came to Chengalpat and became here as a director. Only thing I missed the bus to come to as a director of MMC because of so much of local politics, which they all know. My photo would have come there as one of the retired directors there, but unfortunately it's not there. But I think I have a place in your heart, not on the wall. So, so nice to see you all working here and thing. And I wish him all the best for the future. And thing. Thank you. And sorry, before I finish, Pasupati, my next president-elect, who's also my student, very active fellow, but quite calm and humble, down to the earth man, not like me as a euphoric state. I always been euphoric state, whether it's plus or minus point. He's a very calm, quiet man. I request you to give the support which you all have given me to Pasupati and to carry on the Madras Orthopedic Society with TNOA. Thank you.
Thank you, sir. I would request Professor Trinarayanan, sir, TNOA Secretary, to say a few words. And before that, Professor Amarnath Soli, sir, is honoring our director, Professor V. Singarodira, sir, with a shawl. Professor Trinarayanan, sir, TNOA Secretary.
Respected teachers, Professor Singarodira sir, Pasupati sir, Dean Mohammed Ismail sir, and Sauli sir, Ulga bin sir, Anthony sir, and all the professors and assistant professors. Actually, in government setup, like, these are all very great achievements. And today, seeing such a wonderful, audiovisual aid, which is, I think, the latest technology that is available. It's not available in any of the government hospitals, I'm very sure. And seriously, like, hats off to Singarodira sir and the entire MMC team for having brought this to this prestigious institution. And these are all unimaginable things in government hospital. We should be trying a lot of other hospitals and not happening at all. And to have all these technology, I think this is really wonderful. And we are also moving towards all these levels. And few people like in சில பேர் சும்மாவே இருக்க முடியாது சார் அல்ல சார் வந்து ஒருத்தர் நான் பார்த்துட்டு இருக்கேன். So and I just wanted to read a little bit of statistics. Sorry, just 1 more minute, sir. So we had this we just compiled a few of this because of this brainchild, as Ismail sir had said, our president, the ROCC, BRACE, BOSS program, all these programs were brainchild of Singarodira sir. We had nearly 200 more activities, sir. Only CME programs, we have around 90 programs, instruction course lectures around 30. This is only in 6 months. And achievements of individual members, paper presentations went on. So I compiled this YSS report. It went to 120 pages. And all those photos and other things. So sincere thanks. And of course, the most prestigious institution where all the people of top orthopedics have come out. And though I've not been part of the postgraduate program here, so I was only part of the undergraduate program, and all my assistants and were now retired, and sir was one of my assistants when I was here. Sir is still there. So happy to be really associated, and thanks for the entire MMC team for having invited me. Thank you. Thanks.
Thank you, sir. I would like to request Professor Pasupati sir to deliver the vote of thanks.
Good morning. Respected Director, Institute of Orthopedics, MMC, and past Director and President of TNOA and President of MOS, Professor Amarnath Soli sir. I'm very glad to be a part of this program, and I'm very glad to be with all of you for another 1 year as a president. I'm really lucky to be like this because our past president is sitting here as a director, past director is sitting as a president with the TNOA, and I'm going to be the president of MOS. Very, very, very lucky to be traveling on your shoulder to lead a good orthopedic education for postgraduates. You are also very lucky to have such a nice setup here. So definitely we'll hope for another 1 year, we will have a very good academic. And this opportunity, all the postgraduates has to utilize and come up well. You have a nice opportunity to learn and transfer your knowledge and our knowledge, sharing everything we can have in a better way. Thank you for the opportunity. Thank you, sir.
Thank you, sir. We can see that Professor Manikandan sir has joined online. Sir, are you able to hear us, sir?
Yes, sir. I am able to hear.
Yeah,
Good morning
please.
to all.
Yeah, good morning, sir. Please say a few words, sir.
First of all, I thank my beloved brother, Professor Singarodivil sir, and uh, my president, Professor Ismail sir, Secretary Srinaran sir, and Professor Ismail sir. And thank you for all organizers for inviting me to this. Sorry, I cannot able to attend in person because I am traveling in Andhra Pradesh for my son's NEET exam. So already I informed the Anachi. So I wish you for a grand success, and I also thank the Professor Singadavelu sir for inviting Tirunelveli Medical College as part of this program. Thank you. Thank you for all.
Thank you very much, sir. Thank you very much, sir. So with that, we conclude the meeting. I request everyone to kindly stand up for national anthem.
भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जाहे तव शुभ आशीष मागे गाये तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you, sir. We'll be beginning the case presentation in another 2 minutes time.
This road. This is Raja toll gates. Guntur road. Guntur. That road is only bypass. That is bypass. This is also Chennai. But that is bypass. Bypass. Bypass of the Vijayawada.
ஆமாம். Clinical presentation session. Sir, at Tirunelveli, are you able to hear us? Your video is switched off and you are muted, sir.
Chairlagan, are you able to hear me?
Yeah, loud and clear. Your
Okay.
your
Let us
video is off, sir. Can you switch on the video, sir?
video. Video. 1 minute. 1 minute. 1 minute.
Yeah. Now we are able to see, sir.
Okay. Okay.
Yes, sir. So we'll begin the clinical case presentation. The presenter for today will be Dr. Arun Modi, final year postgraduate, Institute of Orthopedics and Traumatology. And the panelist from Chennai, Professor V. Singarodiolu, sir, Professor Dean Mohammed Ismail, sir, Professor Tolgapian, sir, and Professor Pasupati, sir. And from Tirunelveli, Professor Suresh Kumar, sir. So please proceed.
Right. So we'll be starting the hip session. If there are any questions, the people who are outside who have joined, I am very happy to share that more than 900 people across the country have joined this program. Online they are now. So if there are any questions from anybody, any quarters, they can just put it in the chat box. All the questions will be answered. And Tirunelveli, the faculties can ask the question to the candidate here. And also from here, there must be some few postgraduates from there who can answer. So with that, we'll move on to the clinical case discussion. Right.
மூணு பேர் இங்க உட்கார வச்சிருமா சார் இந்த ஒரு மைக்கை வேணா அவங்கள்ட்ட கொடுத்துருமா இங்கே உட்கார் மூணு
Tirunelveli, till they want to ask question, till then you can mute them because all the things we are able to hear.
நீங்க ஆஃப் பண்ணிட்டீங்க.
Good afternoon, sirs. Myself, Arun Modi, third year postgraduate, Institute of Orthopedics and Dermatology. Presenting long case, Mr. 38 years old male, Mr. Aslam Basha, butcher by occupation, residing at Coimbatore, came to the RGGH with complaints of pain over left hip for past 1 year, complaints of difficulty in walking for past 1 year. History of presenting illness. Patient was apparently normal before 1 year, then developed delta of left thigh, aggravated by walking, relieved by taking rest and medications, no diurnal variation, no rest pain, no night craze. Complaints of limping while walking, which was associated with pain for past 3 months, insidious in onset, progressive in nature, unaided walking, patient able to walk 100 feet, further walking restricted due to pain. History of difficulty in sitting cross-leg, history of difficulty in squatting for past 3 months. No history of trauma or injury, no history of fever, cough or cold, no history of loss of appetite or loss of weight, no history of early morning stiffness, low backache, heel pain or other joint pain, no history of redness of eyes, burning micturition, no history of skin rashes, no history of previous contact with tuberculosis patient, past history, no significant hospital admission, previous hospital.
No, from the, when you are telling about the complaint, you have told about the complaints of pain because you are a little fast. Complaints of pain for the past 1 year and limping for the past 3 months. And it is progressively increasing, right? At present, what are his functional limitations?
At present, patient is not able to sit cross-leg, not able to squat. He's sitting in chair, and he's able to walk only up to 100 feet without any walking aids.
And then he needs a support walk.
He needs a support. He needs rest and support.
Okay. So what was his work, and is he able to perform his work like before?
His work was a butcher by occupation, only standing it. So he's not having pain while standing.
So he's able to continue his walking. I mean, work. These are his limitations, right?
Past history. No previous hospital admission, no history of previous surgery, no history of COVID, no history of comorbidities, no history of prolonged drug intake, no history of similar illness in the family. Present history, personal history, consumes mixed diet, not an alcoholic, smoker for past 8 years, 1 pack per day. General examination.
So from the history, what is your diagnosis most likely to be? So what are the possible diagnoses you want to keep?
Sir, excuse me.
Yeah. Please.
Sir, I'm talking from Tirunelveli. Sir, in between, we couldn't hear you. For our benefit, can you summarize ask the postgraduate to summarize, sir?
Yeah.
Summarize the history. We didn't hear certain parts.
Okay.
Okay. Your voice is not audible, actually. Right.
38 years old male with complaints of pain on the left hip for past 1 year, issue of difficulty in walking for past 1 year, with complaints of limping while walking for past 3 months, and history of difficulty in sitting cross-leg and squatting. with this positive history, I am coming to the
Butcher by occupation, and he is able to stand
comfortably.
Okay.
Unilateral hip pathology, left side.
What are the diagnoses you have in mind?
So, my
So you must broadly classify it into certain things.
Yes.
Whether is it infective, inflammatory, neoplastic, traumatic, metabolic, or any other miscellaneous conditions. So in which condition does this fit into?
This fitting into idiopathic.
No,
osteonecrosis.
idiopathic is at the end of examination, everything if it doesn't fit into.
Okay.
So straight away idiopathic you cannot say. So what are the possibilities you want to keep?
Avascular necrosis of hip.
Straight away. So what point do you have?
Arthritis.
Tell me one point to say that it is avascular necrosis. So that is the diagnosis which you must never say. If it turns out to be, then you are completely prejudiced and your diagnosis cannot be accepted. So you have to tell what is that. That is the reason why I gave you the clue of what broad category you want to classify this. Because you don't have a big clue other than a involvement of the hip. Right.
Trauma, inflammation, other conditions. So no.
Come to a little bit of this broad. Okay, can be an infective pathology or inflammatory or degenerative, whatever it is. You can tell like that. Don't say avascular necrosis as a thing.
With
Is it like a
sir,
inflammatory?
with the available history, I could not able to.
No, with history, you are not supposed to make a diagnosis. What are the possibilities you are thinking means? First, is it traumatic?
No, sir.
It is not traumatic. Is there any point in favor of neoplasm?
No, sir.
Is there any point in favor of metabolic?
No, sir.
Right. So these are the three things. So it could be crystal induced or very rare problems which we do not know, but most likely it is not to be. So what are the other things which are left with? Can it be infective?
No history of infection.
How do you know it is not infective? What are the points to say for or against infective?
Against infective, no history of fever or cough or cold, sir.
Right. What infection you are suspecting?
Tuberculosis.
Tuberculosis infection. So tuberculosis infection, is it primary tuberculosis infection or secondary to somewhere else?
Can be primary.
It can be primary. So how does it be hip joint? So tuberculosis, skeletal tuberculosis cannot be primary unless you inoculate it. Okay. So it can be secondary to somewhere else, primary. So where else the primary can be?
Respiratory system.
Respiratory or
abdominal.
Gastrointestinal. These are the two ways in which it can enter. So if it enters, how long does it take before it comes to the skeleton? So anybody?
6 months to 1 year. 18.
Anybody from Tirunelveli, they want to guess? How long does it take? Primary focus from tuberculosis lung to come into skeleton. So it will take minimum 5 to 10 years. So not necessary that it should be, unless it is biliary or systemic where everything can be involved, usually. So not necessary that you must have a classical fever, evening rise of temperature, loss of appetite, loss of weight, and cough with expectoration, contact with tuberculosis. If they are there, then that is a positive point. But if it is not there, it cannot be a negative point. You cannot rule out tuberculosis, especially in our country, just by saying that there is no. Students always make a mistake like this. So you cannot do it. So because this secondary can be after a long time and it may not have any relationship to that, a primary focus, Gans focus. Okay. So you cannot rule out. So infection is still a possibility. If it is there, loss of weight, loss of appetite, evening rise of temperature is fine. Otherwise, you cannot rule out. Number one. Second, can it be inflammatory?
No history. No history.
Can it? No. I am not asking you to reason out. Can it be?
Sir.
It can. So what inflammatory arthritis? Because seropositive usually involves the small joints, multiple joints, symmetrical joints, swelling, and seasonal variations, and all the other things. So it can be a seronegative. Is there anything to say that it cannot be? Any point to say that it is not seronegative arthritis?
No history of early morning stiffness, no history of heel pain, no history of low backache.
If it is there, then it is all right. I'm asking you a specific question. Is there any point to say that it cannot be seronegative arthritis?
No, sir.
So then these are the possibilities you should keep in mind. So at the end of the history, if you don't have anything, you cannot straight away idiopathic. If there is no diagnosis, you can it is avian secondary arthritis. No. So it can be a degenerative arthritis secondary to some pathology. It can be a secondary arthritis following, that is first diagnosis. It inflammatory. First diagnosis must be, it can be inflammatory. It can be infective. It can be degenerative. See, these are the possibilities at the end of the history. Okay. Anything from Tirunelveli, you want to say anything?
Sir, I'd like to ask a question. Like in his history, the postgraduate mentioned like the walking distance is around 100 feet. Like, is it right in a hip examination to say like 100 feet? We generally tell this about a spine examination. But actually, this question is for you, sir.
Yeah. I understand that. So definitely, because to say how much functional limitation the patient has, we always want at the end of the complaints, what is the functional limitation now the patient has? Whether the patient is able to walk, if at all, how long he is able to walk before he has to take rest, and how far he is able to stand, climb stairs, and sit cross-legged for toilet purposes and meal squatting. So these are the 4 questions we expect, apart from asking them whether he is continuing his work.
No, sir. I asked
if
he's putting a specific number like 100 feet for a hip examination. We don't generally do that. I'm asking, should we tell that? Should we ask the PGs to present like that? Like he's able to walk 100 feet after which he has pain. Then this almost resembles like a spine examination. A clarification. Resembles a clarification.
No. It gives us a clue, idea that how far he's able to walk with or without pain. So here in this patient, for example, he is able to walk for how much distance you said? 100. He is able to walk about 100 feet, after which he cannot walk without a support. So we can understand. No, we can understand if one person says 2 kilometers, I am able to walk. And if turns out to be, because all this history, why do we need is what treatment you are going to offer. 2 things we need from the history. One is from the treatment, whether you will be able to completely cure his problem, whatever complaints for which he has come. So if you say that he is able to walk 2 kilometers, after which he is not able to continue and he has pain. What I will do is, if it is turning out to be a secondary arthritis due to some problem, I'll say that you can wait 2 kilometers at a stretch. If he is able to walk, then it is good enough. Let the limitation happen little more before I give him a treatment. If he says around 100 feet and he has to walk for each and everything for his day-to-day activity, 100 feet only he is able to walk, then I'll say that he needs an active treatment which will benefit him, even if it is little aggressive. So that is the reason, if the candidate says 100 feet he is able to walk, then I'll accept, because I need some number. I need some number. Yeah. Okay.
Sir, let me ask a question to a postgraduate. Because he said a constant distance of 100 feet. What made him to think of a hip pathology rather than a spine pathology? What are the points to think in terms of hip pathology, not a spine one? L5S1 disc can also produce a similar back pain, 100 feet claudication distance, same thing can happen. But what made you to think it's only hip pathology? There are certain clues.
Sir, it is not improved by immediately after taking rest. It takes some time, and the pain is localized only to the hip, not to the radiating to any other place or backaches.
So that point, the radiation, history of radiation, sensory numbness, all those things you can add up. These are not present in this case. That is why I switched over from spine pathology to the hip pathology. And in any case of neurological, it is a classical radiating pain along the posterior aspect of thigh and sensory numbness, which makes you to think in terms of spine pathology. Here it is not so. So you would have thought of that by hip pathology, right?
Okay. Yeah, we'll go ahead. Okay.
General examination. Patient conscious.
erogenic claudication, patient will walk for a certain distance. So after having some minimal rest, he can continue and walk the similar distance. But here he is completing the comfortable walking up to 100 meters. After that, he is having the pain. That's all. The taking rest is not relieving the pain here. And also there is no radiation in like in the spine examination.
Okay.
Yeah. Go ahead.
General examination, a patient conscious, oriented, well built, well nourished, no pallor, icterus, cyanosis, clubbing, lymphadenopathy of erythema, no generalized ligamentous laxity. Inspection on standing position, patient head center, neck center, both both the anterior superior iliac spine at same level, hip in acute and plantigrade position. Inspecting on a patient in sitting position, no exaggerated lumbar lordosis.
There is no difference from is at a different level, or if there is a scoliosis which disappears on sitting, or when the knee level is different on sitting. So these are the three things which you have to comment on sitting. If there are no differences, it is to tell that on standing everything is the shoulder center, anterior spine straight, and there is no exaggerated lordosis. On sitting, you did not say. There is no specific finding on sitting, the same finding as standing. I'll examine the patient. Like you can start.
Inspection on supine position, patient in supine position, no exaggerated lumbar lordosis, both anterior superior iliac spine at same level, hip in neutral, knee in extension, left lower limb more externally rotated than right lower limb, both foot and ankle at position of ease, no limb length discrepancy, muscle wasting present in the thigh region and calf region. Inspection of left hip, on inspecting a Scarpa's triangle, no scar, no sinus, no swelling, no visible pulsation, no dilated veins. Inspection from the lateral aspect, supratrochanteric hollowness is less prominent compared to right side. No scar, no sinus or in the lateral aspect. Inspection of a gluteal region, no fullness of the gluteal region, both the posterior superior iliac spine at same level. On palpation, inspectory findings of no exaggeration of lumbar lordosis and both anterior superior iliac spine at same level are confirmed. On palpating the Scarpa's triangle of left hip, left side, not warmth, anterior joint tenderness present, no palpable mass, both bilateral femoral pulse felt equally. On palpation of a greater trochanter,
There's no tenderness.
anterior joint tenderness present.
Anterior joint. So where did you look for anterior joint tenderness?
2 centimeter below and lateral the mid-inguinal points.
Mid-inguinal point.
Yes.
Right. That is from, where is the mid-inguinal point?
From pubic symphysis to the anterior superior iliac spine.
Okay.
On palpating the lateral side, the tip of greater trochanter migrated proximally on the left side. No thickening, no broadening, surface regular, but trochanteric tenderness present, bitrochanteric tenderness present. And palpating the gluteal region, no palpable mass.
So what do you want to say by pertrochanteric tenderness and bitrochanteric tenderness?
Bitrochanteric tenderness present, sir. So hip, any pathology in the neck of femur, head of femur, or hip joint or acetabulum.
So you are able to transmit the tenderness. Pertrochanteric tenderness, how did you say?
In arthritic changes, pertrochanteric.
Arthritic changes of the hip, will there be a pertrochanteric tenderness?
No, sir.
So is there a pertrochanteric tenderness here? Let's see. Okay, you go.
Postgraduate, can you explain us? Is there any limb length discrepancy on inspection?
No, sir.
But you told there is supratrochanteric shortening is there. There is hollowness is obliterated.
Yes, sir.
Is it not contradictory?
So there is a subtle elevation of the trochanter, but on inspection, we are not able to make out that there is shortening. But on palpating, by doing something like a digital brains, where I keep my thumb in the anticipitoiliac spine, the middle finger in the trochanter, when I am trying to see the distance between the index finger and my middle finger, there is a definitely the trochanter appears little migrated up when compared to the opposite side. But on inspection, I am not able to see the difference. Okay, go ahead. Agreed.
Yes, palpation completed, sir.
You have finished posterior and posterior. What did you say?
Sir, no palpable mass in the posterior region. Posterior joint tenderness present.
So where did you look for posterior joint?
Lateral 1/3 and medial 2/3 junction between the line joining the posterior iliac spine and the greater trochanter.
Oh,
Sir, can we summarize the inspection and palpatory findings, sir?
So on inspection, and I'm summarizing only the positive points, sir. On inspection, thigh muscle wasting and calf muscle wasting present, sir. On palpation, left lower limb more externally rotated than right lower limb, sir. And on a palpation, anterior joint tenderness present, sir. Elevation, proximal migration of a left greater trochanter present, sir. Posterior joint tenderness present, sir.
Doctor, because it is externally rotated, do you want to comment anything special about the trochanter and the size of the, whether there is any thickening, broadening, or the consistency of the trochanter? Do you want to comment on this? Because you committed there is external rotation of the limb. Do you want to commit anything about the trochanter on the right side? Left and pathological side.
The left side. Left is the pathology. Yeah, pathological.
Sir, no, sir. No posterior migration is there.
No, I'm not asking about migration. How is the size of the trochanter?
What are the things you have to say?
So no thickening, no broadening, surface.
No, normal.
Smooth, sir.
Okay, fine.
So the only two positive findings are there is a tenderness and minimal shortening.
Yes, sir. Not
Right?
yes, sir. Yes, sir.
Yeah, continue.
Yes, sir. Moving on to movements, no fixed deformities. I have tested both the active and passive range of movement, describing the passive range of movements. Hip flexion, 0 to 80 degree, further flexion restricted due to pain and spasm, associated with the pain throughout the available range of flexion. Extension, 0 to 10 degrees on both sides. Adduction, abduction, 0 to 10 degrees. Further abduction 0 to 20 degree. Further adduction and abduction restricted due to pain and spasm. Rotation, internal rotation with hip in extension, internal rotation. Degree with hip in flexion, internal rotation is not possible. External rotation from 10 degrees to 50 degrees.
So first we'll see one by one. So you said that the coronal, the sagittal plane, there is no deformity. So how did you make sure that there is no sagittal plane deformity. There is no fixed flexion deformity. Demonstrate.
Yes. With
Right.
with Thomas test, I
Yeah. Please go ahead. So what are you trying to insinuate your finger?
I'm insinuating my fingers up to the knuckles touching the midline.
Okay, right. Then
I am flexing the normal side.
Right.
I'm flexing the normal side hip up to my அந்த கையில கையில அந்த கையில
So the hand should be there or you will remove it. So you maintain the hand all throughout the test so that you can make sure that the spine is always touching the hand, right? Okay. So many people, they say whether you have to put the dorsum or the volar aspect, that doesn't matter. As long as the spine is touching the hand. Okay. The spine is touching and he is kept it flexed. So now there is no flexion. So you say that there is no flexion deformity, right? Now demonstrate flexion, right? Ask him to keep it straight. Okay. Demonstrate flexion. You said 0 to 80 degree. Under there you can just show so that this will be not obliterated.
சொல்லுங்க படுத்துவோம் சரி ரிலாக்ஸ் ஆகிடுங்க சரி சரி சரி
So the available range of movement is complaining of pain. Probably you are not.
சரி சரி படுத்து
Okay. So the available range from 0 to 80 is painful. Okay. Shows the adduction and abduction. Okay. Abduction. You said that rotation.
Hip in extension, left hip internal rotation is not possible, sir. External rotation from 0 to 40.
Right. Can you just show?
With hip in extension.
So with hip in extension, it is better. You can just hold both ankles together and then rotate. So what part of the limb you are seeing to assess the degree of rotation?
I'm seeing the patella.
Right. You have to see the patella. It may be a little difficult. How much is it there?
It's straight, facing the ceiling.
No, on the right side.
I'm difficult to say the actual degree, sir, but it is facing the corner of the.
Okay. So around 20 to 30 degrees. So instead of this, is there any other way of accurately saying how much rotation is in hip in extension?
Yes, sir.
Yeah.
With the patient in a prone position.
Okay. Can you lie down prone?
Yes, sir.
So in hip in extension, to see it with the patellar position, it's very, very difficult. So it is always better if the patient is able to lie prone. கவுந்து படுக்க முடியுமா? இந்த பக்கமா திரும்பி கவுந்து படுத்துருங்க. So to make the patient prone and then to see the degree of internal rotation and external rotation. So now you must be aware that the positions are swapped. Right. I think you can, then you can see. One by one you can do, not necessary to do both. So that is the affected hip. Right.
So internal rotation.
So taking it outside is internal rotation, but the pelvis is moving up. You have to be very, very careful. So is it coming up to neutral? Don't elicit pain, just see. So is it coming up to neutral? நீங்க இந்த பக்கம் வந்துருங்க. இங்க இருந்து பார்த்தா தெரியும். இங்க வந்துருங்க. நான் நிக்கிற இடத்துல இருந்து. இங்க இருந்து காலை ஃபுல்லா. correct. கொஞ்சம் வெளியில கூட வந்துடலாம். Right. So it just comes up to neutral. Okay. So you have to make sure the pelvis is not getting lifted up and then doing internal rotation. I feel that there is some degree of the other pelvis is not getting lifted off, right? So you said up to 50.
Yes, 40.
40. Okay. So this gives us the accurate amount of external rotation, internal rotation. So this is the leg, entire leg acts as a pointer. So from this as the midline, the angle subtended between this line, external rotation. Okay. So this is around 40 degrees, 0 degree to 40 degree in extension, right? So can you make him again? This patient is a very cooperative patient, so we have to thank him. Right. Now you do it in with hip inflection, how much of rotation? So always you must check it with the normal limb first and then go, but it's all right. We'll find out how much it is.
Loose out, free out.
இன்னும் கொஞ்சம் வெளியில முட்டி வரைக்கும் தெரியும். Correct.
With the available range of flexion.
So I have to make sure that the limb is in the axis of the body and it doesn't go out. So you said that there is a fixed slow. Be very slow. So how much rotation?
10 degrees extra.
10 degrees of external rotation deformity. Doesn't come up to neutral. Okay, agreed. Then
check, loose out, free out. Check.
Right. So now the rotation is the angle between this line and the limb. So this is the amount of external rotation happening in that limb. Yes. But you have to keep it as to the axis as possible. Okay. So this is around 50 degree, you mean. So 10 degree of fixed external rotation to 50 degree as the hip is flexed. Okay, right. Yes, then
Measurements. Limb length discrepancy. Apparent shortening of 1 centimeter present in the left side, true shortening of 1 centimeter confined to the supratrochanteric regions.
Okay.
Muscle wasting of 3 centimeter present in the thigh region and 2 centimeter in the calf regions. Special tests. Special tests on drawing the Nelaton's line. The left tip of a greater trochanter passes above the Nelaton's line, and shoemaker's line intersects with the opposite side, opposite shoemaker's line, opposite the midline. On drawing the Keynes parallelogram.
Shoemaker line always intersects. Where it intersects, whether in the supraumbilical or at the level of umbilicus or below the level of umbilicus.
Just below the umbilicus, opposite the midline, sir.
Proceed.
On Chinese parallelogram, convergent on the left side, on Morris bitrochanteric, no change in the Morris bitrochanteric.
What does it? If you are
Morris
hesitating, then we'll go inside. So what does it?
Sir, distance between the comparing the distance between the greater trochanter to the pubic symphysis on both sides, sir.
So how did you measure?
By keeping two parallel hook and, from the greater trochanter to the.
So you kept something. Okay.
In which condition do you think it will be altered?
Then,
Morris bitrochanteric test.
In case of central dislocation of hip or protrusio-acetabulum, can be altered.
Okay.
Yes.
Telescopy test not assessed due to painful, sir. Trendelenburg test, patient not able to weigh peer on the left lower limb. So assisted Trendelenburg test performed. Assisted Trendelenburg test positive, sir.
So positive means what was the patient doing?
The patient putting more weight on the my patient's pathology is on the left, my right.
Assisted Trendelenburg you demonstrate. So don't keep your hand in mind, then you'll get confused. So when he has a pathology in the left hip, with which hand will lean more?
He's leaning more weight on right.
His right hand.
Right.
So that you will not confuse. Okay, so just demonstrate.
No, sir.
So Trendelenburg sign he did not do because Trendelenburg's he did not do because he was not able to stand. ஓ இங்கிருந்து வருதா? So obviously he's not able to stand with a single leg, right? So now you are performing the assisted Trendelenburg, right? To give him instructions.
என் கையில ரெண்டு கையிலையும் தான் வெயிட் பண்ணும். ஃபர்ஸ்ட் நார்மல் சைடுல பண்ணேன்.
So he is trying to stand on the normal side. So which side is he leaning more?
No sir, no leaning up.
So equal weight on both hands, right? Now,
இப்போ
okay, right. So he is leaning more on his right hand. That is the left hand of yours. So don't confuse both. Then in the exam you will always get confused. So if it is left hip in assisted Trendelenburg test, he will be leaning more on the right side. That is what you want. Okay. உட்காந்துக்கோ. Yeah. Gate அப்படியே பாத்துருங்க. Gate. நடந்துங்க இங்கிருந்து நீங்க ஒரு 2 தடவை நடங்க. நான் நடக்கிறது கரெக்டா இருக்கு. Okay. So what gate it is?
Antalgic gate, sir.
Okay. Why do you say antalgic gate?
The stance phase on the affected limb is reduced, sir. And he's lurching to opposite side.
Lurching, don't confuse. Okay. So in antalgic gait, always say that the stance phase on the left side is reduced. So the right side, he keeps it with a thud. The right limb, if you see him walking, he always in a hurry to keep it. So with some force it and he doesn't land smoothly. So that is the thing. So don't confuse this lurch and again get into trouble. Yes, Dr. Suresh, you wanted to say something.
He talked about lurch. That is why he interrupted, sir. Now he changed. In antalgic gait, there is no question of lurching. Just short stance phase. That is sufficient.
Okay.
Doctor, what is the basis of the Trendelenburg test?
Sir, intactness of abductor muscles.
What do you do? I mean, like, what is the basis? I know that is intactness.
Only intactness of abductor muscle, not other than this. There are 3 partners are there.
Any pathology in the abductor mechanism, sir, and fulcrum, liverum, and the force.
No, I'm asking what happens when you ask the patient to stand on the limb. What happens in a normal case and what happens in an abnormal case? That's all.
If in abnormal case, if the patient has to stand on the affected side,
First you say about normal, yes, and then tell about the abnormal.
Normal, if the patient has to stand on a single leg, the opposite side opposite side hip is maintained at the same level, sir.
Why?
The abductors on my abductors of the standing limb is maintaining the opposite hip from drooping down, sir.
Yeah. So which means this muscles help in bringing the center of gravity on the standing limb, right?
Yes, sir.
Okay. Proceed.
Right.
No palpable lymph node, no distal neurological deficit, sir.
So which nodes you want to palpate?
Sir, for hip, I'm examining the hip joint, sir. I want to palpate para-aortic and external iliac lymph nodes.
Para-aortic, you think you can palpate? So don't think all this theory. So external iliac, you can say, I can palpate because here you'll not be able to flex the hip. So you have really deeply flex. Take your fingers parallel to the inguinal ligament and roll it up towards the inguinal ligament. Very, very difficult. I have yet to palpate one external iliac node. But at least there is sake, you can say that external iliac. Don't say as inguinal. But inguinal, you have to make a mention, just any differential diagnosis of a hip pain or the infective process in the limb. That's all. Okay.
Ipsilateral knee and ipsilateral knee joint and contralateral hip joint normal, sir. Chest expansion 4 centimeters, sir. Modified Schober's test range. The difference is 6 centimeters, sir. No sacroiliac joint tenderness. No pelvic compression and pelvis distraction test negative, sir.
Okay. So you want him to summarize?
Yes, sir.
Anything you want to ask from your side?
Yes, sir. Can you elaborate on the differential rotations? We are not able to hear properly because of the network issue.
Okay.
Can you tell what is the rotation, available range of rotations in flexion of the hip and extension of the hip? And what is your inference about the differential rotation?
Okay. Rotation, sir. With hip in extension, internal rotation is not possible, sir. External rotation is from 0 degrees to 40 degrees, sir. With hip in flexion, internal rotation is not possible, sir. Fixed external rotation deformity of 10 degrees, sir. From 10 degrees to 50 degrees of external rotation is possible, sir. With this, the arc of rotation is changed, sir. The available range of motion is same, sir, but the arc is changed from hip in extension to hip in flexions. The available range of motion is 40 degrees in both extension and flexion, sir. Hip.
So what is your inference about this? What clinical interpretation you want to take it from this clinical finding?
Sir, from this clinical finding, the supro-anterior in region of the femoral head could have been affected, sir. So while flexing, engaging, sir.
Is restricted and
Yes, sir. Deviating.
Okay, proceed. Proceed further.
So do you want to call this as sectoral sign?
No, sir.
Okay. So what do you mean by sectoral sign?
The sectoral sign is a differential rotation, sir. The range of motion will be decreased, sir.
So normally, how will it be?
So normally, from hip extension to hip flexion, the patient able to internal rotation, tendency of more internal rotation is available, sir. But in if sectoral sign is positive, the patient could not able to internal rotate, sir. This available range also decreased, and external rotation patient will not able to do internal rotation.
So how much rotation, if it is decreased, you'll take it as significant and you'll say that sectoral sign is positive.
More than 20 degrees, sir.
So more than 20 degree of reduction in internal rotation in flexion. That is called as, so this is not a classical sectoral sign. So
Yes.
there is a deformity in the anterosuperior aspect of the femoral head, which when engages, results in a fixed external rotation deformity of 20 degree, but the arc of motion, which is 40 degree, is still maintained. Yes?
Yes, sir.
Okay, right. Anything else you want to say?
Nothing.
Right. So what is your anatomical, what is your diagnosis?
My diagnosis, anatomical diagnosis, chronic arthritis, sir.
Why do you want to say as chronic arthritis?
Chronicity due to patient complaints of for 1 year, sir, and arthritis due to both anterior and posterior joint tenderness, sir, restricted range of movements, sir, in both flexion, adduction, abduction, and internal rotation, and the available range of movements is painful throughout the range of movements, sir. And
What
1 centimeter shortening is present, supratracheal, sir.
No.
So,
yeah,
1 centimeter.
What is the key clinical finding? Will say it is arthritis. Which points, which clinical point, which made you to think in terms of arthritis, not as synovitis? Because synovitis can also be an external rotation deformity. What made you to think in terms of arthritis? Which clinical points?
Sir, but in synovitis, only the end range of movements will be painful, sir. But in arthritis, the entire range of movements, entire available range of movements will be painful. Sir. Shortening is all 1 centimeter shortening.
That is so because the painful range of movement only you thought in terms of arthritis. There are other clinical, you told it is a fixed external rotation deformity.
Yes, sir.
Fixed deformity is present. 1 centimeter true shortening is present.
Yes, sir.
Both these 2 points are favoring for arthritis. Okay, these points you can tell because this is a fixed deformity and there is a presence of 1 centimeter true shortening. Both are sufficient to make a diagnosis of an arthritis.
Okay. Sir.
Yes.
Okay.
Right. What is your pathological diagnosis?
Pathological diagnosis, osteonecrosis of femoral head, sir.
Again, what are the points to say is osteonecrosis of femoral head?
Sir, the internal rotation, abduction, adduction are restricted, sir. The internal rotation is more restricted, sir.
So what point to say that it is osteonecrosis means that there is avascular necrosis, you mean? Why do you say that? So this diagnosis don't make. So this is what I am repeatedly saying for the past 3 years. Even I could not make any change in our MMC, leave alone making everywhere change. In spite of telling the same thing again and again, saying the same diagnosis. So that is itself says that you have seen the X-ray and you have seen that you have known the diagnosis and your mind does not think anything beyond this. Tell me one point to say that it is avascular necrosis. So anything else can you offer? Yeah.
Doctor, if there is nothing that tells us about the problem, you can always go for a differential, right? You don't have to come to a very specific diagnosis.
So that is the best thing you have to do. You have to give us a differential diagnosis. Sir, I want to give a differential. Right. What are the differential diagnoses you have to give? So you can say even if you want to put it as avian, he is an alcoholic, he has rest pain, he has everything. You can put it as avascular necrosis and arthritis. You have to say as secondary degenerative arthritis. Probably because of that should be your diagnosis. Probably because of avascular necrosis. Here you don't have anything, but still you can put it as what he is saying. Secondary osteoarthritis, secondary degenerative osteoarthritis, probably due to avascular necrosis. Anything else you want to offer? Or you want to stick on only to AVM? So with available, what the people there, what they would like to offer? Anybody from Tirunelveli, anybody they want to offer a diagnosis? Because one or two, you just ask them. So how they will tell? Because I hope that you have heard him very clearly. You have heard him very clearly. So in examination, up to arthritis, chronic arthritis hip, everyone will be saying that, right? Okay. So if that is the case, then what will be your differential diagnosis?
Monoarticular rheumatoid.
Yes. So an inflammatory arthritis. So monoarticular joint, major joint involvement may be rare. So you can put it as inflammatory arthritis. So there is nothing else which you can say no. So monoarticular inflammatory arthritis, common will be a seronegative, but it can be a seropositive rheumatoid also.
Okay.
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 Then
Anything
put it
else?
as anything else?
Tuberculosis arthritis.
Tuberculous arthritis. If it is tuberculous arthritis, what stage it is you'll think and why do you think? So you cannot rule out. I agree with you. It can always be a great mimicker for any disease.
I only told there was restricted with muscle spasm and pain, right?
Yes.
So it can as well be added into a differential.
Oh, you are answering. I thought someone else.
Sorry, I'm answering.
I thought it was okay. Right.
This is not the postgraduate.
Right. So a muscle wasting, gross muscle wasting of 3 centimeters and gross restriction of movement. Definitely it can be. So it is a great mimicker. So it can be. Okay.
Okay.
So with that different, what do you want to do now?
I want to confirm my diagnosis with X-rays.
Right. So that will be a better answer rather than taking all the postgraduates. Don't say I'll do investigations, I'll do TCTC, SR, hemoglobin, everything. When the patient is coming to your consultation room, first you will take an X-ray, find out what it is, and then go ahead and do appropriate hematological investigation. Don't put hematological investigation as first. Slideshow, can you put? You're able to see that X-ray?
Yes, sir. Yes, sir.
Okay. Right. Can you read the X-ray?
Yes, sir. Plain digital X-ray of a skeletally matured individual showing anteroposterior view of a pelvis with both hip joints. X-ray alignment normal, sir. No osteopenia or osteoporosis or sclerosis.
No osteosclerosis. Why do you want to say something which
Generalized.
Alignment means you have to say something.
Both the sentence line
Yes.
is maintained. Good. Okay. Okay.
So central line is
Maintained, sir.
maintained, not broken. Okay, not altered.
Okay.
Then go other.
With
You have
left
to follow the ABCs. A is alignment. Then
bone quality, sir.
yes.
On the left hip, there is a decreased joint space on the supralateral region, sir. And the margins of the femoral head is irregular, sir. And there is a cortical collapse on the supralateral aspect of the femoral head. And the medial joint space is widened compared to the right side, sir. And subchondral lytic lesions are present.
Medial joint space widening may be due to the position of the limb while taking the X-ray, because you told it is fixed external rotation deformity. Can it be due to the position of the patient, doctor, at the time of taking the X-ray?
No.
You still want to, there is widening of the medial joint space and narrowing of the superior space. You want to stick on to that?
Yes, sir.
There is a
Okay,
subtle, I'll agree with him. There is a
Okay, sir.
subtle increase in the medial joint space. There is subtle, because why I say is there is little extrusion of the femoral head. There is little when you compare to the opposite side.
Okay, sir.
So I feel that there may be little increase. These are all very subtle finding. Okay.
Okay, sir. Mm.
Okay. So does it confirm your diagnosis?
Yes, sir.
Okay. MRI is there. Okay.
So what diagnosis you are given? Now you have to change. You have said only chronic arthritis because of the inflammatory and DD. You have given only DD. So you are confirming the DD, differential diagnosis.
Yes, sir.
Now you have to come to the definitive diagnosis after seeing X-ray. Yes.
Okay.
Now we have to say.
Okay.
Now you cannot give us a
With
differential.
the X-ray findings, I want to say
It is an avascular necrosis of femoral. Stage 3, sir. Sir, cortical collapse is there, sir. No arthritic changes in the acetabular region.
X-rays are both sides.
Yes.
Acetabular side right bearing area also you are seeing some sclerotic changes. Clearly.
Okay. Right. What do you want to do?
Sir, I want to proceed with the patient stable mobile hips, sir. Painless stable mobile hips.
Is the right side normal, sir?
MRI is the right normal. Can you just give us MRI?
X-ray also some.
There is some geographic changes, it looks like. Next. But clinically, the right hip was normal.
Normal.
He did not have tenderness and he was able to.
Free range of movement.
Yeah, his movement was. I saw that. Report bilateral femoral head. So that is the reason why you have to take an MRI. For the left hip, you need not take an MRI. But for the right, you must, whether it is stage 0, stage 1, stage 2. Yeah. So there is stage 1. Okay, what do you want to do?
I want the patient a painless, stable, mobile hip, sir.
So what
by,
is your
by giving a primary total hip replacement surgery.
primary total replacement? So what is the problem of doing a primary total hip replacement?
This patient is a 38 years old male, sir. His longevity is more, sir. If I do primary total hip replacement now, after 15 or 20 years, the revision will be difficult, sir. You need multiple revisions.
You may have. So what do you want to do?
I want.
Whether cemented or uncemented.
Okay. Uncemented total hip replacement.
What is the longevity? What do you want to do? It's uncemented.
Sir.
No, one is uncemented.
One is uncemented, sir.
Right.
Another one is tribology of hip, sir. I would advise ceramic on poly.
So you want to change the bearing surface. Don't go into that level. Then if one person is interested in arthroplasty, then he'll start questioning. So bearing surface. Then what are the bearing surface you know of, and what is ideal? Okay. Because it is expected as a postgraduate that you have to know a little more than that. You cannot just stop short of saying that I'll do a uncemented total hip replacement. When we were 35 years ago, when we appeared, we should not say as total hip replacement. Then we will be failed. Now you are permitted to say and you have to say. But when you are saying, then you have to say the next step also. What is the problem and how you can manage. Right? Anything else, Suresh? Or any other questions you want to ask? Am I audible?
Any role of resurfacing? Yes, sir, you are audible. Any role of resurfacing arthroplasty in the current scenario?
No, sir.
Are they doing any resurfacing now?
No, sir. Implant failure is.
Implant failure?
How do you call it? Implant failure or something else? Why it is not in favor, or in the current days, why resurfacing is not done?
One thing is that still the resurfacing has got its own place. It is not like it is completely out of the arthroplasty armamentarium. It is only that now they have found out what are the things which will succeed, what are the things which will fail. So if he is a young arthritic male, size more than 50, 52, head is only partially involved, not completely involved, then you can still go ahead with a metal on metal resurface. The problem, all bad things came because of one design which fell into great disrepute because of the metallosis and the pseudo tumor formation alveolar reaction, I think. So to give you distinction and more than distinction, people will ask all these questions. Okay.
Okay, sir.
So why not ceramic on ceramic? You are going for ceramic on poly on ceramic.
So
it will give more life to the joint.
So,
difficult and it's very common. Squeaky sound or
peri-implant fracture will be more.
The registry has not proved, though theoretically it says that ceramic is the best bearing. But the registry were thousands and thousands across all arthroplasty specialties. Still, it is yet to prove that ceramic on ceramic performs little better than ceramic on poly. So these are all for the information. So still, the best bearing surface as per registry is only ceramic on poly. So, okay, then the squeaky sound, what is the complication? Then you may have to say about squeaky.
Sound on eccentric loading will give some psychological problem.
It's the most worrying thing. Every time night when he gets up for his washroom, then if the hip is squeaking, his partner cannot sleep. So it is really an annoying noise. You have to hear. Okay, in YouTube you can find out ceramic on ceramic squeaky sound. Extremely, extremely annoying noise. கீச்சுன்னு நம்ம போட்டு நகத்தை வச்சு கம்பி ஏத்திக்கிறோம். Okay, right. Okay, if that is, can we just leave him, the candidate? Okay.
Yes, sir.
Yes. Okay.
Thank you, sir.
Thank you.
Thank you.
Nicely done. And any questions on chat box or anything? Any questions have come? நீங்க அடுத்த
Chat box, sir.
ஏதாவது இருக்கா பாருங்க. அடுத்த patient.
So we'll finish short case from there.
Yeah. Short case.
So we can have short case from Tirunelveli, sir. Hope the
Yes, sir. We are ready. We are ready, sir.
Yeah, please go ahead, sir.
Please go ahead.
Okay, sir. Few minutes or one minute, sir. I will bring the patient inside.
நம்ம பேசிட்டு எங்க? அவங்கள சொல்லிரு. இது வந்து ஒரு ஸ்பாட்டர் மாதிரி.
ஓபில உட்கார்ந்திருக்காரு.
He can walk.
பண்ணலாம் சார். வாக் பண்ண முடியும். இல்ல சார், அவரு இது எக்ஸ்பிக்ஸ்ல இருக்கு. ரிசல்ட்
வாக் பண்ண முடியுமா?
கேக்குது. கேக்குது.
Can assisted Trendelenburg also can be done in a fixed deformities.
Fixed deformities like
Rotation deformities are lean.
இல்ல அதான் அதாவது why do you do a test? To get some information about which you do not know. That is the reason you want to find out, just not for the fancy of it. So if that being the case, any fixed coronal plane deformity, that will not give you any additional information. The same way, if he is not able to stand and if he is actually is able to do assisted Trendelenburg only, if it is painful or anything, he will be pushing only on the opposite side. So that will not give you any information. That cannot tell you about the intactness of the gluteus medius abductor mechanism. It can never give you. What we want is integrity of the gluteus medius, the lever on the head, neck and trochanter, and the fulcrum. So all the three components it cannot check. Then what is the point of doing? You may be able to do it and the patient will lean more on the other side if there is deformity, if any one of this thing is wrong. But that doesn't give you any value added information for doing this test. That is the reason. Still you can do. Yes,
Thank you, sir.
you are ready, we can go ahead.
Sir, you can go ahead at Tirunelveli, sir.
Okay, we are ready. Nakul is our final year postgraduate.
Please
Present the short case. Nakul, you can start.
Good morning, sirs. My name is Dr. Nakul. I'm finally a postgraduate from Tirunelveli Medical College. I'm here to present the short case. So my patient is a 16-year-old male who came to the ortho OPD with complaint of a swelling over the left back of shoulder past 6 years and a swelling and pain over the left back of shoulder for the past 1 week. So history of present illness. The patient was apparently all right 6 years prior to the date of admission when he noticed a swelling over the left back of shoulder. The swelling was insidious in onset. It was non-progressive. It was not associated with any pain at the time of noticing the swelling. There were no incidents of any other, no history of any other multiple swellings in any other part of the body. Coming to the pain, the patient had a pain for the past 1 week. The pain was insidious in onset. It was not progressive. There were no diurnal variations and no radiation. There were no exacerbations or remissions. The patient also gave a history of a gritting or a grating sensation over the shoulder during overhead activities or while lifting heavy objects. There was no history of any loss of weight, loss of appetite, no history of any trauma.
1 second, sorry to interrupt you, Nakul.
Yes, sir. Yes, sir.
Yeah, you said about pain. Where is the pain?
Yes, sir.
And
So pain,
you
pain
have
was
not
present
mentioned
over the
about
left back of shoulder, sir.
left back of the shoulder only.
Yes, sir.
Okay. And when is it present? All the time it is present constant, or is it present intermittently only when it does some activity?
So pain is present. The slight pain is present all the time, sir. But it is aggravated during overhead activities and while lifting heavy objects, sir.
Okay. Is he able to comfortably lie down in the bed?
Yes, sir. Yes, sir. He's able to comfortably lie down, sir.
Okay, right. Go ahead.
Yes, sir. So
What
there's
is his
no
age,
history
you
of it.
said? What is his age?
16-year-old male, sir. 16-year-old
16.
male, sir.
At the age
Yes,
of
sir.
10, he noticed the swelling.
Yes, sir. Yes, sir. He noticed the swelling at the age of 10, sir.
Okay, okay, please go ahead.
Sir, there's no history of any loss of weight, loss of appetite. Coming to past history, there's no previous history of any swellings in the past. Family history, there's no history of similar swellings noticed in any member of the family. General examination coming to.
Yeah, please go ahead. Is there anything
sir.
you can present it as a short case? You need
Yes,
not
sir.
elaborate on everything. You can just
Okay, sir. Okay, sir.
only relevant things. Yeah.
Okay, sir. The patient is a thinly built, moderately nourished patient. There's no pallor, no icterus, no clubbing, no lymphadenopathy, no edema in the left upper limb. Coming to inspection. There's a swelling of the attitude of the patient. The patient is sitting comfortably on the couch. The shoulder is in adducted position. The elbow is flexed. The forearm is in mid prone position, and the wrist is at the position of ease. So the swelling there are multiple swellings on the medial side of the medial border of the scapula. Of that, two were present on the medial border of scapula and one on the posterior aspect. The size of the swelling was all three swellings were 2 cross 2 centimeter. The surface of the swelling was found to be smooth, and the shape of the swelling was found to be hemispherical. The skin over the swelling, there is no discoloration over the skin, discoloration in the skin over the swelling. There are no visible pulsations or dilated veins.
Go ahead.
The skin, yes, the skin. The skin over the swelling is not stretched or shiny. So going to palpation, sir.
No. Inspection itself, you can see some more things, no? What has happened to the scapula? You are selling.
Yes, sir. There's a mild elevation of the inferior angle of scapula. Sorry, sir.
Yeah, always while presenting a short case or whatever in orthopedic problem, you have to tell about the problem and what has happened to the nature of the bone. Any bone, what you are seeing, is it naturally looking, or it is broadened, thickened, or is it in anatomical location, or elevated, lifted? And simultaneously, you have to look at the soft tissues also. There may be wasting of the muscles. The tendons may be prominent, tendon may be shortened or contracted like that. So you have to see and tell. So about interesting finding in this case.
Yes, sir. The inferior angle of scapula is found to be elevated. The bone is slightly elevated. So there are 3 swellings over the medial border of this bone.
That you finished, yeah.
Yes, sir. No other significant inspectory findings, sir.
Is there any wasting? Are you able to appreciate?
No, sir. No wasting, sir. No wasting in any muscle groups found around the scapula, sir.
Okay.
The infraspinatus, does it look normal? Because from here it looks like it is wasted. It looks.
Inspection.
Is it inspection? Does it look wasted?
Yes, sir. There is muscle wasting. Yes, sir. There is a muscle wasting. The supraspinatus is also in the infraspinatus.
Because
and comparing to the other side, there is.
The spine of scapula is more
prominent,
compared to the opposite side.
Other side.
And
yes,
there
sir.
is supra-infraspinatus wasting. Don't just blindly say. Not necessarily that they should always have a suprascapular nerve palsy or compression or anything. So whatever is present, you have to tell. Okay. And one more point.
Yes,
in addition to getting, the inferior angle of scapula is more prominent. Is it also shifted, or the scapula, is it rotated? Lifted?
Yes, sir. The medial border is more prominent than the medial border of scapula. Yes, sir. Medial border of scapula looks more prominent, sir.
Okay.
No, if you see that distance from the center of the spine, no? How far it is when compared to the normal side. This is the distance also, it is little bit increased. You can
Yes, sir, it's
appreciate it.
increased.
Yeah.
Yes,
That
sir.
means it
Yes,
is
sir.
lifted and moved laterally. That you can say.
Laterally, sir.
Yeah. Fine.
So that comparison you have to make, because these are all things which are very obvious. Is it rotated? Is it more prominent? Or is it gone more laterally? All the three aspects.
Okay, sir.
Okay.
So,
Now you can go to palpation.
yes, sir. Going on to palpation, all the inspectory findings were confirmed on palpation. There was no warmth. No, there was a slight tenderness at the site of the bony swelling. The swelling was smooth. The smooth border, smooth. The well-defined edges and well-defined hard in consistency. It was fixed to the underlying bone. The skin over the swelling was found to be pinchable.
Your video, I think, connection is lost. Can you just find out? So far, it was very, very clear. The video feed is lost.
Back again, sir. 1 minute,
Yeah,
sir.
yeah, yeah. Ah, right. Now we are back. Okay, go ahead.
Yes, sir. So skin over the swelling was found to be pinchable. There was no compressibility or reducibility of the swelling.
So what is the consistency of the swelling?
Hard in consistency, sir.
Then we need not expect it is to be compressible, no?
Yes, sir. Hard in
The
consistency.
hard
Sorry.
swelling.
Yes, sir.
How you?
Fixed to the underlying bone, sir.
No, you have to go like that. No, you have to locate the swelling first. You have
Yes,
to
sir.
locate the swelling. Normally, in a palpation of the scapula, we have to palpate. You start your palpation by palpating your spinal scapula. Okay, you have to start from laterally. You run your finger along the spine of the scapula. Yeah, you are doing correctly. Do it on the normal side. Yeah, what you are doing, run your finger along the spine of the scapula and you turn it around.
Again, your video is lost. Yeah, now a different perspective we are seeing of your department.
So usually you have to go. Yes. Yes. So similarly, you do the palpation on the affected side now. Yeah. So from where to where you are noticing the swelling now?
The swelling is on the medial border of the scapula,
Yeah.
sir.
Otherwise called as what is the
level of
border? Middle border or what do you call it? The middle border of the scapula is otherwise called as Napa. Vertebral border of scapula. Huh? Okay.
Thanks, sir. So it's present on the vertebral border of the scapula.
Yeah,
There
is
are
it,
three
is it
numbers.
a
Sorry, sir.
single swelling or it is how
It's
far it is extending?
multiple swellings, sir. There are two swellings at the medial border of the scapula, and there is one swelling on the posterior border. This is one swelling, and there are two swellings on the medial border of the scapula, sir.
That is not the posterior border, that is the body of the scapula. That is the
Posterior
medial border
of the body of
posterior
scapula.
surface. Correct.
Surface.
Is it attached to the scapula or it is arising from scapula? How do you know that?
Ask the patient to. I will check for the movements of the scapula.
Just you can hold some swelling. No, if you are arising from the bone, if you are able to hold the base of the swelling, that means that will give an inference. No, what kind of swelling it is? Is it?
It's attached to the scapula, sir.
Okay. Is it a single swelling lobulated like that, or it is different
No.
swelling?
It's different swelling, sir. 3 different swellings, sir.
Different swelling.
How do you make out that it is three different swellings? The surface looks bosselated and three different this thing surface you are feeling. But how do you know that it is not from a single swelling? These three things have come. Can you be very sure?
No, sir.
Okay. You can't be.
No, sir.
So if you want to know the medial extent of the swelling, how will you know that? How do you do that? Suppose scapula is a flat bone, no?
Yes, sir.
It is lifted up. That means there is a possibility of the swelling can extend to the other surface of the scapula also.
On the
So you
anterior.
yeah. You have to know that also. So if the scapula is lifted like that, this swelling have every possibility to go anterior and lift the scapula. So you have to know the extent. That is very important in this case.
Yes, sir.
So you can either
ask the patient to do scapular retraction, sir.
Yeah, how will you make the scapula to? What muscles makes it to?
Retraction of the scapula is done by rhomboids minor and rhomboids major, sir.
Yeah, do that. How will you test for that?
Arm is adducted, humerus is slightly extended. Now I'll ask the patient to, while I give I try to abduct the shoulder, I'll ask the patient to adduct, sir.
The camera can go little back and show how he's doing that. Yeah. Yes.
Nicely you are doing. So you are able to see the swelling, palpate and find out anything which is, the swelling is going there.
Going medially also, no?
Yes, sir.
Anteriorly also it is progressive.
Yes,
So the deeper surface, the deeper surface of the scapula also it has got the extent. Okay.
Yes.
So now you want to give redefine your findings. It is not three separate swellings.
Yeah.
It is only single because on retraction of the scapula, you find a swelling in the anterior aspect also. It could be generally a single swelling.
Okay. Okay. Palpation. After that, movements I check for retraction, protraction, and elevation of the scapula. All these movements were found to be comparable to the opposite side.
Can you demonstrate the movements? How
Yes,
much
sir.
is up? Yeah.
First, I'm showing demonstrating elevation. I'll ask the patient to keep his to adduct both shoulders, and at the same time, I'll place my hand on his place on the hand on the trapezius, and I'll ask him to shrug his shoulders.
So why do you want to resist that movement? You want to check the passive range of movement or you want to check the muscle?
Check the
not necessary, no?
Okay, sir. Yes, sir.
Right. So you just check the movement. We want to see the movement. What is the movement? Because we don't expect any paralysis.
Paralysis, yes,
No
sir.
compression. Yeah. Okay. All the movements. Okay.
Sir.
Right.
Yes, sir.
All are symmetrical.
Yes, sir.
Then abduction, adduction.
இப்படி பண்ண கை மேல தூக்கு ஷோல்டர் இப்படி கை மேல தூக்கு தூக்கு ஃபுல்லா தூக்கு இந்த கை வேண்டாம் ஃபுல்லா தூக்குடா மேல வர தூக்கு டில் பண்ணிடுடா
No, that's all right. We are able to see. So the other side also.
இந்த கை கீழே போட்டுட்டு இந்த கை மேல தூக்கு.
No, both simultaneously can be done.
Yes,
both ask him to do it simultaneously. Is the abduction equal?
We have to always test the abduction, doctor.
That is the key.
Whether he is
full maximum abduction.
Maximum abduction.
Ask him to touch the ear. Yeah.
இது காதுல தொடணும் சரியா பண்ணுவோம்.
Okay. Then we are convinced.
Yeah.
Okay.
This is fine.
Next.
This movement we have to always test. In many of the scapular pathology, this may be affected. So always you may have to ask the patient whether he is able to touch the ear while doing this abduction like this. If that is affected, definitely there will be some problem, especially in the pharyngeal shoulder. That is very important.
Okay, any other thing you want to show us? Right, what is your diagnosis?
I would like to give a differential. The
And is there on
benign.
during movement, Nakul, and
Yes, sir.
during movement, is there any crepitus or anything which you are able to feel? Because you are saying that the patient was feeling.
I'm not able to feel, sir. The patient gives
You are
a
not
history of
able
grating
Ah.
sensation. I'm
But
not
you
able
are
to
not
feel a
able to-
crepitus, sir.
No crepitus anywhere. During abduction, adduction, you
Kai
checked
mela
over the swelling?
Ukra.
No. Is that the way you check for crepitus? Is it the way you check for crepitus or anything else? You can just keep your palm of hand over there. Why do you want to keep your finger? No, just over the
over.
scapula. You need not show us anything. You can
Just
just
cover
cover the swelling. Keep your hand over there. Fully. You just keep everything. Yeah. You just keep it and ask them to correct. Abduct.
ಈ ಮೇಲೆ ತಗೊಡ
Fully.
Full
Fully
നല്ല
ask
ಮೇಲೆ
him to-
ಹಾಕು, ಮೇಲೆ
Ask him to do it fully. Right.
Yes,
Is there
yes,
any
I can.
crepitus?
Yes, I can feel a crepitus.
Now
That
you
is the
will be
most.
able This is also a very important finding. You will be able to appreciate in shoulder with this kind of problem.
So feeling for the crepitus, because that is his main problem. So you have to find out what is the cause. Here it is very obvious. There are a lot of cases where you will not be able to find out the cause for the crepitus. The patients will be saying and you will be also feeling, but you will not be able to find out the cause for the scapulothoracic crepitus. Okay, right. So now what is your diagnosis? Differential you want to give?
Uh, a benign swelling of the scapula, sir.
What differentials?
So what
Differential,
makes it benign? Why do you say it's benign?
Benign because there is no the first the patient had swelling followed by pain. In history, the patient had swelling first followed by pain. There was no sudden increase in pain. Coming to inspection,
No,
there was
the
no
pain-
discoloration of the.
No,
Sorry,
one
sir.
minute. The pain you said that it is only for the past 1 month.
1
or
week,
so.
sir. 1 week,
One
sir.
week. So
Yes,
then
sir.
it means that it is sudden pain only. Is it not? 6 years it's been there, but 1 week he has got pain.
Yes,
Now
sir.
you say that there is no sudden pain. Okay, proceed.
So in inspection, there is no skin discoloration found over the swelling. The skin over the swelling is not found to be shiny or stretched out. There are no dilated veins or visible pulsations over the swelling. The surface of the swelling was found to be smooth. The borders and the edges and margins were found to be well defined. All these point towards a benign swelling, sir.
Benign swelling, yes, okay.
Okay, what is your pathological diagnosis? Clinico-pathological
What common
diagnosis.
benign swelling you will get there? What is the commonest?
Osteochondroma, sir.
Right. You wanted to offer a differential diagnosis. What are the other diagnoses you had in mind? So if there are few cases, can you offer any differential? Because in my mind, I am not able to.
No, sir. Sorry, sir. Osteochondroma. sir.
Yes, don't say. There may be some surprises. We don't know. But with the bosulated swelling on the scapula for 6 months, 6 years, I'm not able to find out any other benign swelling. Right. So in that case, you can just say benign swelling arising from the middle part of the scapula, probably osteochondroma.
Osteochondroma, sir.
Okay, right. What do you want to do?
First, I would wish to investigate the patient, sir. First, I would like to take an X-ray.
What X-ray you'd like to take?
A shoulder AP view and a scapular Y view, sir.
Very good. So you must not take just like that axillary view or lateral view, a shoulder Y view. Okay. Can we have the X-ray?
Yes, sir. Yes, sir.
அவங்கள
Dinesh sir, are you able to do screen sharing or are you having any difficulty?
Sir, 1 second, sir. Huh? Request to allow. Sir, you have to allow us to share, it seems. You can
Just a
request the
minute, sir.
host to allow multiple
Yeah.
sharing for this meeting.
Yeah.
Yes, sir. Yes, sir. We'll do that. Yes, sir. I think you can share now. They have made you host.
Yes, sir. 1 second.
Yeah, we are seeing it. We are seeing the X-ray.
X-ray. இது போடுதா போடு. அதான் full screen போடுங்க. இப்போ நான் full screen போட்டுக்கோங்க. Sir, is it visible?
Yeah. Very
Is
clear.
that,
Yeah. We're able to see. You can make it as a screen show. I mean, slide show. You can make it as a slide show.
slide show போடுமா? Full screen போடு, first slide show. அதை ஓபன் பண்ணி பெருசா காமி. Right. அதை பெருசாக்கிறேன் இல்லைனா?
இந்த பவர் பாயிண்ட் ஸ்லைட் ஷோ போட முடியலையா?
அப்படி இருக்கட்டும்.
அத பின் பண்ணுங்க இல்லன்னா. ரமேஷ் இல்லன்னா அந்த ஸ்கிரீனை பின் பண்ணுங்க.
ஷேர்ல தான் இருக்கா?
ஓ, அது பின்ல தான் இருக்கா? அதான் அதனால தான். சரி இருக்கு, இதுலயே நல்லா தெரியுது. டோன்ட் வரி. அதே
Okay, sir.
இதே நல்லா தான் தெரியுது. You can describe about the swelling.
Read the X-ray, Nakul.
Yeah.
Sir, can you hear me, sir?
Yeah.
So the first X-ray is a plain X-ray of the shoulder joint AP view of a skeletally immature individual, showing a well-defined bony lesion on the medial border.
Sir, Dinesh sir, நீங்க அந்த ஸ்லைட் பிரசன்டர் வியூவை டிசேபிள் பண்ணிடுங்க. ஏன்னா இங்க சின்னதாயிடுச்சு.
சரி, ஒரு நிமிஷம்.
லேப்டாப்ல ஸ்லைடு பிரசன்டர் வியூன்னு இருக்கும். அதை டிசேபிள் பண்ணிட்டு
ஸ்லைடு பிரசன்டர்
ரைட் கிளிக் பண்ணுங்க. இப்போ அப்படியே ரைட் கிளிக் பண்ணுங்க.
ரைட் கிளிக் பண்றேன். அதுல வச்சு பண்றேன். அதுல வச்சு ரைட் கிளிக் பண்றேன். எக்ஸ்ரே போடு.
ஹைட் பிரசன்டர் வியூ கரெக்ட். அதை ஹைட் பண்ணிட்டு
ப்ரீவியஸ் இது போ.
இப்போ ஃபுல் வியூ தான் வருது.
இப்போ ப்ரீவியஸ்
ஓகே. இப்போ ஓகே. பியூட்டிஃபுல்.
ஓகே சார்.
It's a plain X-ray of the shoulder joint AP view of a anteroposterior view of a skeletally immature individual, showing a well-defined bony lesion on the medial and the anterior border of the scapula. The second X-ray shows a scapular Y view, showing a well-defined lesion extending into the anterior border of the scapula.
So don't keep on saying as anterior border of scapula. It's only anterior surface of the scapula.
Surface of scapula, sir. Sorry, sir.
Okay. The borders are very well defined. Yeah.
Posterior also.
Yeah, the posterior also,
Posterior,
there is an
yeah.
extension. Okay. Yeah.
Can I go to the CT, sir?
No,
Is there
what kind of swelling it is? Is
One
it
second. Yeah.
diffuse or you can see a little bit of peduncle also, no?
Yes, sir. Pedunculated swelling, sir.
Yeah, it's a pedunculated exostosis. Okay.
Yes, sir.
The ribs are normal.
There's some
Any compressive effect?
Ribs.
Is the tumor doing something to the chest wall?
Yeah, it is showing some effect on the chest wall.
Sir. There's
What do you
compression
call
on
it
the-
as? Any structure pressing over other structure? Scalloping effect.
Scalloping effect.
Yeah, scalloping effect.
So the scalloping effect on the ribs.
Ribs.
Okay,
Ribs, yeah.
next. Next slide.
Yes, sir.
Yes. Okay, so that is the cut showing that tumor.
Yes, sir. The
Okay.
cut section of the tumor. Next
Yeah,
slide.
yeah. Next slide. Okay. Yeah, yeah. Next one. So one swelling which peduncle and the anterior surface which goes to the anterior as well as it comes to the posterior aspect. That looks like that. இல்ல?
Yes, sir.
ஒரே peduncle
ஒரே படம்.
which comes also to the
Posterior.
posterior surface going round the vertebral border. Okay. Next. So there is a good effect on the rib. We can see.
Ribs, yeah. Yes, sir.
Yeah, yeah. Okay. But, ஆமா.
Ah, yeah. Snapping.
Yes. So the amount of indentation it has got on the ribs, chest wall.
Ribs, sir. Yes, sir.
Yeah, yeah. Okay. Right, what do you want to do?
Uh,
So here one of the student wants to know the cartilage cap thickness. Do you have that? The MRI report?
we are the patient 2.9, sir.
2.9.
It is just about
Yeah, significant. Two is,
two is up to two
more
is
than two is,
accepted. 2.9 is little bigger cartilage cap.
Cartilage cap.
Okay. Right, what is your plan?
We plan to to do an excision biopsy, sir.
Okay. So ipsilateral lymph node, was it examined?
Yes, sir. There's no lymph node swelling, sir.
So what are the nodes you checked?
The axillary lymph nodes, the 5 groups of axillary lymph nodes and the deep cervical lymph nodes, sir.
Okay. Right. So you are planning for an excision. So what incision and how are you planning to go to the anterior surface? Have you developed? So this is a very, very interesting case discussion. I really thank and appreciate the Professor Manikandan, Professor Suresh Kumar, Dr. Dinesh for their effort. So that was a brilliant, for the first time when you are doing as a host, and you have really showed a very good case, very, very interesting patient, and it was very clearly demonstrated. I thank everyone there for having showed it. Thanks, Suresh and Dinesh. Thank you.
Sir, the
Thank you very much, sir. It is
former
a great
person is
opportunity
waiting there
for
to
us
honor
to
them.
interact with you. So teachers for us, for many of us here, you are teacher, and it is very much happy. We are very happy and glad that our students also benefited by your knowledge and wisdom, sir. Thank you very much, sir.
Thank you, Suresh.
Thank you,
and,
sir.
They are,
The former
you're
person is waiting there, I
waiting
think,
to be to honor you people. Yeah. So if Corona persons are there, they'll come there and they can honor so that we can also have a look. They are there?
One second, sir.
Yeah, yeah.
Till the time we'll honor the panelists here. Sir.
Yeah, yeah.
Shawl. I request Professor V. Singarodi sir to honor Professor Tolgapian sir with a shawl. Light போட்டுருங்க. ட்ரே இருந்தது. ட்ரே இருந்தது. சரி கொடுங்க. ட்ரே கொண்டு போயிட்டாங்க. சார் ஸ்டேஜ்ல வந்துடுங்க. ஸ்டேஜ். போட்டோ. And Professor Pasupati, sir. Sir. இல்ல சார் அப்ப பண்ணல அதான் Sir, Professor Pasupati sir on stage. இல்லைங்க சார் செப்பரேட் சார். Hope the former person at Tirunelveli, have they come into the hall, sir? We can have the spotter.
Sir, here actually the Corona people have not turned up. I think
Okay, sir.
we'll meet them later, sir.
Okay, sir.
So
Fine.
there is one more
spotter discussion. We have one spotter discussion,
Yes,
sir.
spotter. It is a very, very
Slide
interesting patient.
Screen share.
Shall we ask one of our PGs to?
Yeah, sir, definitely.
Okay.
History lende podunga. History lende podunga.
History da? Right.
Slideshow.
So one postgraduate to read and we'll ask some questions.
Are you able to see the slide, sir? You're able to see, Dinesh?
No, sir, not yet, sir.
Just a
Okay.
minute, sir. Just a minute.
இப்ப நீ ஹோஸ்ட்ல தானே இருக்க?
ROCC.
இல்ல நாங்க இந்த க்ளூ தரேன் எங்களுக்கு தெரிஞ்சா.
தப்பான இங்கிலீஷ் சொல்லக்கூடாது.
Are you able to see, sir?
Now we are able to see, sir.
Okay.
that
So
is a-
can you just ask someone to read and then
Okay, oh, sure, sir, sure.
Mr. Rajasekhar Reddy, a 42-year-old male from Andhra Pradesh, presented with complaints of pain over left wrist and difficulty in using left hand for past 2 months. 2 months before, history of RT and sustained injury to left hand and right leg. Patient was initially taken to a nearby hospital and was treated there.
So, hey, next. Clinical image.
இது அதெல்லாம் ஐயோ அப்பா. So this is the clinical image. Go to the X-ray. So this is the clinical image and this is the X-ray. Can you just tell the diagnosis?
So there is a peroneal dislocation. There is a spilled coffee cup sign.
Very good. So spilled coffee cup, it indicates what?
So lunate has dislocated.
So there is
That's-
difference between a lunate dislocation and a
Perilunate.
perilunate dislocation. So the lunate has come out. And right. So when you
AP.
see this AP view, there is what
Teddy
is that?
Thomas.
Yeah. So you have the increased space and you see in the lateral view very clearly the lunate has come out. Okay. So when this X-ray is seen, what is the next thing you will see?
So associated fractures and scaphoid fracture and nerve injury, sir.
What nerve injury you want to see?
Median nerve interrupted.
Very good. Right. You just go to the clinical picture. So what is that you want to see now here? This
So
is
as
this
a
way.
muscle wasting is seen, sir.
Yeah, where wasting?
So thenar muscle wasting is seen, sir.
Right. So what other thing you are seeing? How does the, you are answering brilliantly. You have to say, thenar muscle wasting is seen. And then, next, what should you see? What is the attitude?
Aptum deformity, pointing index finger.
Now, pointing index now you cannot see, no?
Sorry.
And do you see pointing index when the lunate is dislocated and median nerve is pressed? Do you see
No, sir.
pointing index?
No, sir.
No, because the nerve to the flexor digitorum profundus goes higher up.
Forearm.
Yeah, in the forearm level. Now we are seeing in the wrist level median nerve compression. So there is a wasting of the thenar eminence. Then the attitude is aptum deformity. Is there a aptum deformity here?
No, sir.
No, this is the appearance of the aptum. Don't expect the ape to come here. Okay. So you have to imagine. So what do you mean by aptum? What do you mean by aptum? So what is the difference between normal thumb and ape thumb? You have to see only the supinated forearm. Don't look at the forearm. Pronated forearm. Look at the picture of the supinated forearm and then tell. What do you mean by ape thumb? So what is the normal orientation of the thumb? And what do you mean by ape thumb? Is it present in this patient?
So it is in same plane.
Correct. So normally how it should be?
It has to be in it should be abducted. Perpendicular to the surface.
Exactly. So when you see the nail, when you see the pulp, it should be perpendicular to the pulp of the other fingers. The nail should be perpendicular to the nails of the other fingers. Correct? So now you see here, how is the thumb looking? Is it getting supinated? Is the thumb also coming in the same plane as the other fingers?
Yes, sir.
Now with that eyes, are you able to see anything? Imagine.
Yes, sir.
So this is slowly it is getting rotated. So the thumb is gradually becoming supinated. The pulp is started appearing because if you take a photograph from this side, this is not straight photo. This is taken little from the patient's radial side. In spite of that, you are able to see more of the pulp, which is more than what we normally see. Okay. So this is the ape thumb. Any other clinical photo you have got? This is the only thing you have. Yeah, you should, any video, anything, you should have made that. So the patient has sensory loss in the median nerve distribution and the loss of opponents. He is not able to do it. He is able to only adduct. So that video you should have produced. We thought that we will be, I thought you would have done everything. Okay, so this patient is having a classical median nerve compression. Okay, right. Okay,
that completes the case discussion. So we have a feedback.
Yeah, so with that we will have the completion. Any chat box, anything? Ramesh, chat box so that completes. So you have answered brilliantly. So the lunate dislocation, and you got the medal in this quiz or something from Tirunelveli. You people only got, right? One of them.
Yes, sir.
You got it. So that was brilliant answer. Really appreciate it from here. So immediately you were able to answer and tell all the right things. So we'll just give the feedback QR code. So please scan the QR code and give your feedback regarding the audio quality, the video quality, and the timing, whether you want to have a change in timing. Please scan and then give the feedback. Any other topic discussion you want to have apart from the clinical class or any surgical approaches or any videos or any specific cases, definitely we'll be trying to get those cases and show any specific signs you want to see. Definitely we'll try to organize and then we'll try to give it. So you just scan this and you'll have the feedback form. Feel free to give all your feedback because the subsequent every month, second Saturday, we are planning to have between 12 to 2. You want change of timing or anything based on the majority, we'll try to change that. Okay. So you have all scanned?
Yes, sir. We will submit the follow-up feedback, sir.
So I think 2 o'clock, we are well in time and we have completed. We had a useful discussion. So once again, I thank all those people who have joined with us. Thank Tirunelveli Medical College, all the faculties, especially our President-elect, Professor Manikandan, Professor Suresh, Dinesh, and all the people who are gathered there. And the postgraduate students who enthusiastically participated and answered brilliantly. Any last few words from Suresh? Yeah.
No, sir. Everything went on well, sir. It's a well spent time, sir. Thank you for the opportunity given to us, sir. Thank you, sir.
Thank you. Thank you. Thank you so much. Thanks.
Thank you.
I thank here Chair Ladan, especially for doing everything and behind anything, any program we say, and Dr. Sherladan is there to get it done very smoothly. And I thank Corona Remedies again for the technical support. Thank you.
Thank you, sir.